they're each a separate lecture, but I will just highlight some of the key elements of epilepsy and anxiolytics so that you can say you were exposed to both of those disorders. Coming back to the glutamate receptors, you'll recall that just like with the GABA system, there's a class of glutamate receptors that are essentially ion channels, intrinsic ion channels, and there's another class that are metabotropic and coupled through G proteins to affect. And we were talking about the ionotropic ones as I ran out of time, and so we'll just follow up on that. Their nomenclature has evolved over the years, and I have barely kept up with this. You don't need to memorize any of this. Just know that there are three classes that essentially were defined initially based on ligands that were selected for them. And so we all think of them as the AMPA class, the kainate class, and the NMDA class. And there are subtypes of each of these. The AMPA glutamate receptor is the business one, the main one that mediates fast synaptic excitation. Just like the GABA-A receptor is really the predominant receptor that mediates fast synaptic inhibition, AMPA receptors are really the initial drivers of excitation, and you'll see what that is in a second. Kainate and NMDA are also very important, but so the general structure is a little different from the GABA receptors. Recall that they had four clear each subunit had four transmembrane domains, and 5 subunits come together. Our best understanding of glutamate ionotropic receptors is that kind of 3.5 transmembrane regions. We used to think the second one came all the way through the membrane, but it clearly does not. And so this is what they look like. And instead of 5, they're tetramers. 4 of these subunits come together to form an ion channel that binds the agonist glutamate, and instead of being permeable to anions like chloride, it's permeable to cations, sodium, and in some cases calcium. Now the AMPA receptors, as I said, mediate most fast synaptic excitation in the central nervous system, and they have 4 subunits. These blue are 1 to 4. The one piece of biophysics I'll talk about briefly is that most of them contain the GluR2 subunit, and if they have the GluR2 subunit, they're only permeable to sodium. And if they're missing the GluR2 subunit, they're actually appreciably permeable to calcium. And as you'll hear in various lectures, calcium is an absolutely critical signaling molecule. It's really, really important. The ionic gradient for most ions is 2 to 3 orders of magnitude across the membrane. So for sodium, you might have 100 and something millimolar outside, and maybe 10, 20 millimolar inside. For calcium, extracellular calcium is 1 to 2 millimolar. Intracellular free calcium is in the low nanomolar range. It's highly, highly sequestered. And that's because calcium is a critical signaling molecule, not just for neurotransmitter release, but for engaging all kinds of signaling cascades. And so if AMPA receptors, which are really ubiquitous and mediating fast synaptic excitation, have appreciable permeability to calcium, then they can affect all kinds of signaling plasticity in addition to just polarizing the membrane. I'm not going to talk much about kainate receptors. In the earlier part of my career, I studied them extensively. They're really confusing. They mediate fast synaptic excitation in some specialized synapses, but not widely throughout the brain. They're also found presynaptically, and they have really complicated effects on synaptic transmission. And this is just showing that a kainate agonist can actually facilitate AMPA transmission. So these are spontaneous glutamate responses. And in the presence of an agonist kainate receptors, you can actually see an enhancement of glutamatergic transmission. This is a presynaptic effect. So they're located at both sides of the synapse, and their physiological role is still under investigation. The NMDA receptors probably receive the most attention in pharmacology because it is permeable to calcium. So it's permeable to sodium, and it has appreciable permeability to calcium. And because of that, it's known to be important in a number of signaling cascades. And you've all heard, I'm sure, of synaptic plasticity. I think I'll talk very briefly about that. NMDA receptors are very important in strengthening and weakening synaptic excitation and inhibition in many parts of the brain. And because they're permeable to calcium, all NMDA subunit assemblies are permeable to calcium. They are highly regulated. Unlike the AMPA receptors, glutamate is not sufficient to activate NMDA receptors. You need a whole host of things to happen. Some of them are just there tonically, but others have to happen. They have a requirement for glycine. So in addition to glutamate being the neurotransmitter, glycine has to be bound to a distinct site. And there's enough glycine in the cerebrospinal fluid that site is usually engaged. But there is this requirement for this glycine site. There are many, many modulatory sites, polyamine sites, proton sites that can essentially allosterically modulate and regulate the NMDA receptor. But the biggest one is that at the resting membrane potential, magnesium ions essentially plug the pores of these channels, and so they can't conduct sodium or calcium. They can't depolarize the resting membrane potential, even when glutamate binds. The only way to get the magnesium out is for something else to initially depolarize the membrane. So that's why I was saying the AMPA receptor is really the initial driver of synaptic excitation. It has to initially depolarize the membrane potential to relieve this magnesium block, and then the NMDA receptor can participate. So it comes, at many, many synapses, you have both AMPA and NMDA receptors at the postsynaptic density. But when glutamate essentially is released, the first thing it does is engage the AMPA receptors. They begin the depolarization. That relieves the magnesium block, and then the NMDA receptors can participate. So you can imagine that if the synaptic strength is not all that strong, the NMDA receptor is not really going to be able to contribute much. But if the stimulation is intense, you get a big enough depolarization, then the magnesium block is relieved and NMDA receptors can participate. So they can kind of gauge the strength of synaptic activity, and that's how synaptic plasticity can get engaged. If the stimulation is relatively weak, the NMDA receptors don't get engaged, you don't get plasticity. But if the stimulation is really strong, then the NMDA receptors can get engaged. So some people refer to them kind of as coincidence detectors. When there's convergent excitation onto a neuron, the NMDA receptors are the receptor that says, oh, hey, this is a really intense, important stimulus. I'm going to get activated, relieve the magnesium block, and engage synaptic plasticity, maybe long-term potentiation or something like that. There is an extensive network of proteins that you do not have to memorize at all that regulate the synthesis, trafficking, and targeting of these glutamate receptors to the membrane. This is not even close to a full picture of it. And I often try to wonder how all these proteins can actually fit in something as small as a dendritic component. But they do. And they're really important in moving these receptors to the membrane and taking them back in and regulating their distribution at the synapse. In terms of pharmacology, I told you that for the AMPA receptors, they're called AMPA because AMPA was the drug that was first used was found to be a selective agonist of these receptors. Quisqualate's also an agonist. There are some positive allosteric modulators of AMPA receptors, a drug called eneracetam and cyclothiazide. And these drugs have been thought to maybe be cognitive enhancers. If you strengthen glutamatergic transmission, you might be able to enhance cognition. And so they've been tried as cognitive enhancers. You gotta be careful playing around with AMPA receptors because they're so critical in regulating excitability that if you overstimulate AMPA receptors, you'll have excitotoxicity, and that's not good. Lots of antagonists, these are largely just used in the laboratory. They would theoretically be effective against, anything that's involved in too much excitation, like epilepsy or stroke or something, that neurotoxicity. But of course, the problem is if you block AMPA receptors, you shut down the brain and you don't have consciousness, and so they're really not used clinically. Although there are some allosteric antagonists that people are trying to develop, and there's one now that's FDA approved for epilepsy, and I'll touch on that briefly. So in terms of the physiological role of glutamate receptors, well, they're essentially responsible for synaptic excitation throughout the brain. So wherever you have excitatory communication, the ionotropic glutamate receptors, and primarily the AMPA ones initially, are mediating this. And of course, they do play a central role in synaptic plasticity. I'm sure have all heard of long-term potentiation. This is sort of the synaptic correlate of how we think memories get laid down. You can stimulate a pathway and measure a synaptic response that's mediated mostly by AMPA receptors. And if you stimulate it every 10 or 20 seconds at just a normal frequency, that response will be stable for as long as you can record it. But if you deliver high frequency stimulation just for like less than a second, and this is the kind of stimulation that might happen if a circuit that's involved in memory formation gets engaged, what happens is when you go back to stimulating at the normal frequency, you see a long-lasting enhancement of this AMPA receptor receptor-mediated synaptic response. So this synapse has been strengthened for a very long time, and many, many studies have shown that pharmacological and genetic manipulations that block this long-term potentiation also block the formation of memories in the circuits that are involved. So many studies were done in the hippocampus, which is an important part of the brain that regulates spatial memory, learning where things are in a grid or in a maze. And you can study rats and see that you can give them manipulations that block this long-term potentiation, and those rats are unable to learn the spatial memory task. Conversely, you can do things to enhance this long-term potentiation, and those rats become better learners. So there's pretty good evidence that this long-term potentiation is the synaptic representation of how the memories get laid down. So again, in theory, as therapeutic targets, people have thought about targeting AMPA and kainate receptors for a variety of things, neuroprotection, neurodegeneration. But again, because these receptors mediate synaptic excitation, which is essential for almost everything the brain does, they're limited in their use. Again, there's some evidence that positive modulators of AMPA receptors may be useful in the treatment of disorders involving memory impairment. These drugs are not yet FDA approved. I touched on epilepsy. I'll talk about that more in the epilepsy part of the lecture. There's some evidence that glutamate receptors, including the kainate receptors, actually play a key role in pain transmission in the spinal cord. And people have been trying to develop drugs that would be selective for spinal AMPA or kainate receptors. And in theory, that would be an effective way to treat pain, but I don't think any of those medications have really progressed. The NMDA receptor has been focused on a lot more because of its important role in signaling. And again, you don't have to memorize any of the drugs. I just want you to understand sort of how the drugs work, and I'll touch on the drugs that are really important that you might want to remember. But these are just some of the agonists and antagonists that we use to study NMDA receptors in the laboratory for the most part. As I mentioned, because the NMDA receptor is permeable to calcium, it's blocked at the resting membrane potential and only engaged with relatively high frequency stimulation. It seems to be really important in a whole range of neurological disorders. So all of these different disorders, people have shown that NMDA receptor expression or function in various parts of the brain is altered. And so people have tried to target the NMDA receptor. And there are a few drugs that I think that are showing promise that are FDA approved. Memantine, which is a use-dependent blocker of NMDA receptor, is actually beneficial in Alzheimer's disease. And you've probably seen commercials. I forget the trade name for this drug, but there are commercials on TV for it. And it seems to help slow the progression of cognitive deficit in Alzheimer's disease. Ketamine is a really fascinating drug. It's a use-dependent blocker of NMDA receptors. And it's used as an anesthetic, so you use it in the laboratory or in the clinic as a rapid anesthetic. It was discovered a while ago that ketamine is actually a rapid antidepressant. So I don't know if you've had a lecture on depression yet, but all of the drugs that we use for depression, they're quite effective, but they take 2 to 3 weeks to start having their effects in relieving depressive symptoms. Ketamine relieves depressive symptoms immediately, and the effect of a single injection can last for a couple of weeks. It also has it can have psychotic effects, and so it's kind of a little bit dangerous to use, but a lot of people are advocating careful use of ketamine and ketamine-like compounds, perhaps, for the treatment of depression. And there's some recent controversy about whether or not this antidepressant effect is even through the NMDA receptor. It may be some different effect that it has. But nevertheless, ketamine you may see in clinical papers. And acamprosate is a kind of a dirty drug. It's a weak allosteric antagonist of NMDA receptors, but it also interacts with the GABA system and calcium channels. And it's FDA approved for the treatment of alcohol use disorder. Very briefly about the metabotropic glutamate receptors. Just like with the GABA system, back in the 80s and 90s, it became apparent that there was a different class of glutamate receptor that was not sensitive, that was not mediating rapid changes in membrane potential. It became apparent that these were G protein coupled receptors. And this is kind of what they look like. Again, I'm not going to dwell on this for you. And these are their signaling cascades. There's 3 main groups, and there are subtypes of mGluR receptors that signal through different signaling cascades. Some of them are excitatory, and some of them are inhibitory. Definitely don't need to memorize this. This is just a list of some of the compounds that are used to study these receptors. What I do want you to remember is that just like with the GABA B receptors, metabotropic glutamate receptors are found both pre and postsynaptically. So they exert their effects on synaptic transmission both pre and postsynaptically. Presynaptically, just like with GABA B receptors, they can, when activated, they can act as autoreceptors to inhibit glutamate release. And postsynaptically, they can engage signaling cascades to contribute to synaptic plasticity and modulate neuronal activity. So that's the key point to remember. They're found pre and postsynaptically. That's basically what this slide says, that they're involved in a variety of forms of synaptic plasticity, and again, pre and postsynaptic. The other thing to remember is just like with the GABA B system, although they're certainly present at most glutamatergic synapses, they're also found at other types of synapses. So GABA synapses, dopamine synapses, serotonergic synapses. So these, particularly presynaptically. So they act as what's called a heteroreceptor at these other neurotransmitter synapses to regulate the release of other neurotransmitters as well. This is just illustrating some of the neuromodulatory effects. Again, in the interest of time, I'm not going to dwell on this, but you can review for yourself that activation of these different metabotropic glutamate receptors can have pretty dramatic effects on, action potential frequency or the size of synaptic responses. And these receptors have been implicated in many of the same neurological disorders as their anatropic counterparts. But because they're metabotropic and they signal more slowly, and their effects tend to be more modulatory rather than mediating fast synaptic excitation, a lot of drug companies have really put a lot of effort into developing compounds that would target these receptors for the treatment of the same disorders that I listed before. Unfortunately, unless things have changed, I haven't looked in the last few months, despite maybe 10 or 15 years of work, none of these medications have gotten through all the different stages of FDA approval. And so we still don't have mGlu-R receptor drugs in the clinic, even though preclinical studies strongly suggest that these are viable targets. It's just sometimes hard to get a medication approved for other reasons, but there's still a lot of interest in that. All right, any questions about glutamate? If not, I will move on to what this lecture is supposed to be about, which is essentially anxiolytics and anti-epileptic drugs. And these are standalone lectures, but I'm only going to highlight some of this is actually a review of things we've already talked about, because it won't shock you that GABA receptors, which are the inhibitory receptors, are prominent in anxiety disorders, and both GABA and glutamate receptors play a big role in epilepsy. And so some of this will be review, and I can just gloss over that. So the real point of this part of the lecture is just to give you a little bit of a basis for the physiological substrates that contribute to anxiety and anxiety disorders, how we treat them, and how we treat them. And again, I'm going to focus on the traditional drugs that are used to treat anxiety disorders have targeted the GABA A receptor system. Have you had a lecture on depression yet? You did. So you learned, I don't know if they focused on this, but antidepressants are now the main treatment for anxiety disorders. But since you've already learned about the antidepressants, I will talk to you about the benzodiazepines because they are still used today, and there are some reasons why they still have a place in the treatment of anxiety disorders. So when you think about stress and anxiety, the definitions are really pretty easy to keep in mind, because these are the things we all feel all the time. Everybody knows what stress is. It was formalized by a physiologist about 100 years ago, almost, named Hans Selm, who sort of defined stress as essentially the response to demands upon the body. So whenever anything is sort of putting a demand on your body to respond, that creates a stress, and your body has to be able to respond to it. And fear and anxiety are really critical emotional responses that are vital for survival. Fear is an adaptive state of apprehension to an immediate threat. If a lion suddenly walked in here and you didn't show a fear response, you wouldn't be around for very long. And so Fear is a perfectly normal adaptive response that's vital for our survival. Anxiety is also important, and it's a more long-lasting state of apprehension or tension or uneasiness in response to a perceived threat or stress. And again, anxiety is perfectly normal. If you didn't study enough for a test and you're about to write a test, you're going to feel stress and anxiety, right? But prolonged, intense, and most importantly, inappropriate periods of anxiety are when we start to worry that there may be an underlying disorder. So if you're feeling anxiety because you didn't study, that's not an anxiety disorder. If you did study, you got an A, and you're still feeling anxiety all the time, that's when you might start to think that there could be some underlying problem. And that's what people with anxiety disorders really experience. They're suffering symptoms like you feel when you're anxious often, and at times where there's no obvious reason for that to happen. There's a physiological, essentially the circuitry that's driving your normal anxiety is being engaged at an inappropriate time. You probably have seen this millions of times, that stress activates the classic hypothalamic pituitary adrenal axis, which in concert with other physiological responses essentially coordinates your body's behavioral response to the environment. And you get release of corticotropin hormone, a corticotropin releasing factor, which engages in symptoms, and it feeds back into the brain to inhibit further activation of this circuit. That's a classic inhibitory feedback. And cortisol is the critical hormone that mediates that. And this is thought to mediate a lot of your peripheral responses. And all the organ systems can be impacted by this. What I really want to emphasize today is that over the last decade or so, we've come to appreciate that there's a stress axis that's happening above the HPA axis in the brain that is vital as well for mediating a lot of the emotional experiences associated with normal anxiety and anxiety disorders. And this is probably the circuitry that's getting dysregulated in the disorders. And I'm not going to dwell on this in great detail, but modern circuit mapping techniques, we have actually identified specific circuits in the brain between regions like the basolateral amygdala and the hippocampus and central amygdala that you can turn on and off with opto or chemogenetic techniques and literally elicit an anxiety-like behavior in a rat or a mouse, or decrease an anxiety-like behavior in a rat or a mouse just by flicking a light switch. And so we're getting a handle on these circuits, and a lot of human neuroimaging studies are really showing us that these brain regions and circuits within these brain regions essentially have gone awry in these neurological disorders, in anxiety disorders. And one of the reasons that these disorders really need to be addressed, I mean, you could think, okay, I feel anxious all the time, it's not the end of the world. Persistent disruption of the HPA axis and these supra-HPA circuits in the brain leads to many neurological consequences in addition to just those uncomfortable emotional feelings. And so there are many studies that have shown that people with anxiety disorders also have immune system dysfunction, cognitive deficits, increased vulnerability to psychiatric disorders, cardiovascular problems, GI problems, and in fact the area that my lab focuses on is a much higher risk of developing drug and alcohol use disorder. And so left untreated, anxiety disorders have very detrimental effects on many other organ systems. And so it is really important to try to address the underlying problems. Just briefly, people with anxiety disorders are 2 to 4 times more likely to develop alcoholism. And those people that do have anxiety disorders, they're actually diagnosed 5 years younger than people without anxiety disorders, and their prognosis and recovery is really dismal. And so not only are anxiety disorders associated with things like drug and alcohol addiction, they exacerbate each other. And so it's really important to try and address this. In terms of symptoms, you all know these because they're the same symptoms that you would experience with normal anxiety. There are physical symptoms. Your heart rate might start to increase, tension in your muscles, sleep difficulties are very common, and of course there are psychological symptoms that also manifest. What are the causes of anxiety? Well, as I said, they're perfectly appropriate under normal stressful circumstances. Lots of drugs can acutely affect anxiety-like behavior as well. Alcohol acutely is very anxiolytic. It decreases anxiety-like behaviors. But if you drink excessively for prolonged periods of time, when you withdraw from the alcohol, you actually see really dramatic increases in anxiety-like behavior. And that's part of the reason we think the comorbidity is there, because you start drinking to relieve that anxiety, that negative affective state that manifests in withdrawal. Stimulant drugs like cocaine and nicotine actually can have acute anxiogenic effects. They can increase anxiety-like behavior. And so can chronic cocaine and nicotine exposure. And nobody smokes. Does anybody smoke? You won't lift your hand because you shouldn't be smoking anymore. But smoking,
it's played out.
What's that?
No.
Nicotine. Smoking nicotine, at least, is very, in a naive person, it really doesn't affect anxiety-like behavior. It might even be a little bit anxiogenic. But in smokers who are addicted and they're in withdrawal, they feel really high levels of anxiety. Often that's very powerfully relieved by the smoking. And then there are biological factors, of course. And these are under active investigation right now. Go through this really quickly. There's this thing called the Diagnostic Statistical Manual. This is the Bible for psychiatrists and psychologists to diagnose psychiatric illnesses. And every few years they update it just because they need something to do, I guess. Now they're hoping to try and improve treatment and focused research in the right area. In the DSM-4, which was in place until a couple of years ago, this was the way anxiety disorders were broken up. There were these 6 or 7 disorders. Generalized anxiety is the most common one you think about. This is your classic anxiety disorder where you have excessive, long-lasting worry, tension, that kind of thing. Panic disorder is a more specific type of where acute panic attacks occur very in discrete time frames. You've all heard, I'm sure, of post-traumatic stress disorder. This can arise due to people in the military are particularly vulnerable to this, but it can happen to anybody who experiences a traumatic event, and it can have really devastating effects and can be quite hard to treat. There are specific phobias. Social phobia had its own class. This is fear of being out in social situations, but fear of spiders or clowns or whatever is a specific phobia. And then obsessive compulsive disorders, where you have these essentially, you obsess on things, and you develop these compulsive behaviors to try and relieve the obsessions. And so like every time you leave a room, you might have to turn the door handle 3 times and that kind of thing. And as you can see, although benzodiazepines are used in the treatment of many of these, as I mentioned, classic antidepressants like serotonin reuptake inhibitors have really become the gold standard, and that's because these drugs are so well tolerated, and they are very effective for anxiety symptoms. Obviously, the feelings of anxiety and depression are very different, but they frequently co-occur, and they're frequently, even though the feelings are very different, they involve very similar circuits in the brain, and it is not that surprising that drugs that would be useful for the treatment of one would also be useful for the treatment of another. But benzodiazepines have the advantage of working very quickly, and their effects are very robust, and so they're still prescribed today for the treatment of anxiety disorders, although usually just for shorter durations. I'm not going to go into this in any detail at all, but in the new DSM-5, they've really changed the categories, and really what they've done is created a whole list of anxiety disorders that lists all of the phobias and the generalized anxiety disorders and some other ones together. And the important thing is they've separated out obsessive compulsive disorders into their own category. And I'm not going to go through these, it's not important, but they really have their own class, and that's because many feel like the neurobiology that underlies these disorders are distinct. And then trauma and stressor-related disorders, particularly post-traumatic stress disorder, have their own category as well, because we think there may be some underlying differences in the neurobiology that drives these disorders as well. In terms of gene-environment interactions, there's definitely a genetic basis for anxiety disorders. So twin studies have highlighted that if one identical twin has an anxiety disorder, the other is more likely to develop it. But it's nowhere near 100%. It's not like Huntington's disease, where if one twin has the gene for Huntington's disease, the other is 100% going to also have it. It's more in the range of 20 to 30 to 40%, depending on the type of anxiety disorder that you're looking at. And there's been a lot of interesting work showing that there's really strong gene-environment interactions between, in terms of the development of anxiety disorders. And this is an interesting one. It used to be thought, and actually it's still thought today in some studies, that the size of your hippocampus can actually be what was driving the anxiety disorder. So there's evidence that chronic stress actually might shrink the hippocampus. It actually causes an atrophy of the hippocampus, and that this could contribute to the symptoms. But some elegant imaging studies put a different spin on this. What they showed was that your hippocampal size is actually very strongly genetically influenced. So identical twins have roughly the same size hippocampus, not that surprising. But what they found was that a large hippocampus is protective. It provides resilience to the development of PTSD, post-traumatic stress disorder, and a small hippocampus actually increases vulnerability to PTSD. So if you have a big hippocampus and you're exposed to combat experience or not, your likelihood of developing post-traumatic stress disorder is pretty low. If you have a small hippocampus and you're exposed to stress, to a traumatic event, your likelihood of developing PTSD is quite high. Now, even if you have a small hippocampus but you've never experienced traumatic events, probably won't develop PTSD. So it's not causal, it's not driving the effect all by itself, but it does increase vulnerability. And the model that my lab has been using with great success actually in rats is that early life stress, doing something during development, and all we do is raise our rats in single cages. That's the entire stressor. Single housing them during adolescence so they can't play with each other. That sets up big changes in their behavior that essentially look like they are vulnerable to anxiety disorders like PTSD and alcohol use disorder. So there are key environmental factors that definitely influence the development of these disorders. And I told you that most research now is really focused above the HPA axis into the brain, and powerful imaging studies are really highlighting that parts of the brain that get activated during normal fear and anxiety show exaggerated responses in people with anxiety disorders. So here's a composite image of just some normal control subjects being shown fearful visual stimuli. And you can see red is hot. This is a hyperactivation of the amygdala, which is mostly comprised of the basolateral amygdala in humans. And you can see that when you're exposed to a fearful stimulus, the amygdala tends to light up. And then these are images of people with different types of anxiety disorders. And you can see that they also show a response, but it's an exaggerated response. And in some cases, they'll show this response even during neutral stimulus presentations. And so we're getting a handle on, in gross terms, the underlying brain regions that have gone awry. And what current work is trying to do is to figure out ways to reverse this susceptibility. So an anxiolytic drug is obviously a drug that's used to treat anxiety disorders. All of these drugs typically, well, except for the SSRIs, all of the drugs that were used prior to that also have sedative, hypnotic, and at very high doses they can even have anesthetic effects. Sedative is a drug that depresses CNS function, leading to a calming or relaxed state, which can be okay, but sedation also leads to hypnosis, which is drowsiness and falling asleep. And that's something you don't want if you're trying to function. And that's part of the reason that benzodiazepines, have somewhat been replaced. In terms of how these drugs were discovered, this is true for almost every neurological disorder. We rely heavily on animal models of disease, animal models that have predictive validity, so the drug that relieves the behavior in the animal model and is shown to have that drug has effects in the human model. That's predictive validity. And construct validity is when the underlying neurobiology that's driving the behavior in the animal is the same as that drives the human condition. And we hope that those models provide better treatment. I'm not going to dwell on this too much, but there are some really interesting tests of conditioned anxiety-like behavior, and the most common one is called the fear, potentiated startle paradigm, and this is a really powerful one. What you do is you train a rat to associate a neutral stimulus like a light with something aversive, like a mild shock. And And this is a highly translational assay because the same procedure can be done in humans where you pair a neutral stimulus with an aversive stimulus, like a mild shock or a loud noise or something like that. And then what you do is, in the rats, you deliver on this, you do this for one day, maybe 10 pairings of the light with the shock. And then on the second day, you deliver a series of acoustic tones to startle the animal. And they do the same thing in humans. They'll deliver acoustic tones to cause a startle response in the human, and they use the eye blink reflex for the humans. In the rat, we can actually measure their whole body startle response because they're much smaller. And what you do is you present a series of tones, and it's the same decibel level tone. Half the time the tone is delivered alone, the other half of the time the tone is preceded by the light that was paired with the shock the day before. And it's not hard to imagine that if the animal has learned this association, then when the light precedes the tone, they're going to startle more. And that's exactly what happens. That potentiated startle response is because the circuitry that's involved in anxiety has actually been engaged by the light and potentiates the normal startle response. And so people try to find drugs that will reverse the startle response and not affect the basal startle response. And even more interestingly, what you can then do is try to extinguish this learning. And what you try is, you're actually not erasing the memory, you're creating a new memory that the light is now saved. So what you do is, after the animals form this association, put them back in this box, and you just keep showing them the light over and over again without shocking them. And a healthy brain will learn that the light is no longer a danger signal. And then when you repeat this test, they should no longer show a potentiated startle response. But patients with post-traumatic stress disorder, they have a really hard time forming that safety memory. They have a really hard time learning that this is no longer a danger signal. And in some of our animal models, we see the same phenotype, that the animals have a really hard time learning that the light is not still associated with the shock, suggesting that the circuits that are driving this behavior essentially have gone through plasticity that's making them very resilient to these changes. There are simple tests of unconditioned anxiety-like behavior. It's kind of hard to see this. This is called the elevated plus maze. This is just a forearm maze that's raised off the floor. And in the actual maze, I don't know why I keep using this one, these are dark and dark plexiglass. So the animal will feel safe in those compartments. The other two arms are open. And what happens is the animal, when placed on this assay, avoids the open arms and spends much more time in the closed arms. But if I give the rat or a mouse a benzodiazepine, they start wandering out in the open arms like everything's just fine. And in fact, this was the assay that led to essentially the development of benzodiazepines back in the 50s. So it's still widely used today. And then there are pharmacological experiments or techniques where you can inject a drug that will produce an anxiogenic behavior. So we'll go very quickly through this because we already talked about benzodiazepines a little bit last time. But these were by far the prevalent drug from the 50s until really the last 5 to 10 years for the treatment of anxiety disorders. This is their structure. And the most popular one is Valium. This drug came out in the late 50s, early 60s, and was just widely prescribed for many, many years. It's still heavily prescribed today. I'm not going to go through the pharmacokinetics in detail. You can read through this too, but most of these drugs, this is what I do want to emphasize, is that all of these drugs are clinically used today. They all have the exact same mechanism of action. Remember, these are allosteric potentiators of GABA A receptors, and yet they're marketed for a variety of different diseases like generalized anxiety disorder, alcohol withdrawal seizures, insomnia, even though they all have the same mechanism of action. And the reason that they're prescribed for different reasons is because, basically based on their pharmacokinetics. Some have really long half-lives, so you just take one pill a day, and others have much faster pharmacokinetics, so they're broken down much more quickly. And so, for example, if you have a hard time falling asleep, but once you sleep, you're fine, you would use a really short-acting drug like Halcyon to treat that kind of insomnia. But if you have generalized anxiety disorder where you're feeling anxious all the time, you would want a drug like Xanax that has a much longer half-life. And these drugs also differ in their potency. And so it's really their potency and their metabolism that have led to how they were marketed for different purposes. They all have the exact same mechanism of action. So obviously they're used for anxiety disorders. They also have anticonvulsant activity, so some of them are used for epilepsy, but again, they've also been replaced because better drugs have been brought to market. The one type of seizure that is still treated with a benzodiazepine is alcohol withdrawal seizures. People who've been abusing alcohol for a long time and then withdraw suddenly are very vulnerable to a severe type of seizure that can actually be fatal if left untreated. And so if they present at the clinic, they're immediately given an IV dose of a high amount of benzodiazepine, and that usually stops those seizures, not always. They have muscle relaxant effects due to interactions with spinal transmission and sleep disorders. They used to be used much more for the treatment of sleep. I'll just share one interesting thing about benzodiazepines and the sleep cycle. You have different stages of sleep. You've probably seen this before if you're measuring the eye from just regular muscle or the EEG, electroencephalographic activity. You progress through these different stages of sleep where your muscles gradually get more relaxed, and then your brain activity gets more and more synchronized. And then you go into this deep stage of sleep called REM, rapid eye movement sleep. And with these really rapid eye movements, you're actually paralyzed. Your muscles are completely paralyzed. And brain activity gets very, very quiet. And you cycle through this. And these are really the restful parts of sleep, the stage 4 REM sleep. And what benzodiazepines tend to do is they reduce sleep latency. So this, from being awake, which is stage 0, to falling asleep, that does get faster. You fall asleep faster. And it increases this early stage of sleep, stage 2, but it actually decreases the amount of time that you spend in these deeper stages of sleep. So people who take these drugs will report that they slept better. What they're really feeling is that they fell asleep faster, but the quality of their sleep may not have actually been improved that much. And also tolerance develops to this effect over time. So benzodiazepines, again, are really useful for acute 1 to 2 week treatments, but it's not something you can rely on a regular basis, because eventually you become tolerant to this. These drugs were so popular for so long because even though they have side effects, that they're sedative and hypnotic, they were better than the other drugs that preceded them. And although they do have some, unpleasant side effects, these are relatively rare and minor. There are memory deficits. I'm going to go through that very quickly, but there are benzodiazepines that are known as date rape drugs, which cause anterior grade amnesia, which is the inability to remember things that happened very recently. And so that is a real side effect of these drugs. And there are a number of interactions. Benzodiazepines enhance the effects of alcohol and other sedative hypnotic drugs. And I'm going to emphasize that a little more in a minute. Tolerance certainly can develop to many of the effects. What's kind of interesting is the anxiolytic effects, the anti-anxiety effects of benzodiazepines, they don't seem to develop, tolerance doesn't seem to develop for them. So even though if you're taking this drug, for a few weeks, the sleep-inducing effects may go away, other sedative effects may go away, the anxiolytic effects persist, which is interesting because we think the GABA receptors are driving all of this, and yet somehow the anxiolytic effects are persistent. We don't have a good understanding of that. Certainly, chronic use of these drugs can promote dependence, and if you've been on one for a while, you don't want to suddenly withdraw, you want to taper off the use of the drug, and it is that dependence that doctors worry about with protracted use of these drugs. And they are completely contraindicated in pregnancy. They're associated with cleft palate and cleft lip. So these drugs should never be prescribed to a woman who's pregnant. And in terms of toxicity, these drugs have a high therapeutic index. I think I mentioned this last time, and so I'm not going to dwell on this, but it's important to remember that benzodiazepines alone have rarely been associated with death, and so if people have attempted to commit suicide by taking a very high dose of benzodiazepines, they tend to just sleep for a very long time and wake up none the worse for wear. And the exception I usually emphasize is alcohol. There are many, many unfortunate cases where somebody has been using both alcohol and a benzodiazepine, and the two potentiate each other and can lead to respiratory depression and death. And what I want to add here, I didn't put it on the slide, but I've been reading a lot more about the opioid epidemic that's out there, and you've all heard of this, right? How opioid abuse and deaths associated with the abuse of prescription opioid drugs. and other types of opioids is sort of out of control. It's particularly bad in North Carolina. What I didn't know was that about 25% of the people who OD on these opioids are also taking benzodiazepines. Alcohol as well, but benzodiazepines are also heavily implicated in the mortality associated with opioid abuse. So although I often talk to students and tell them that these drugs aren't very safe, we have to start thinking about how much they're prescribed and what else the people are being prescribed and what potential there is for these drug-drug interactions. Any drugs that depress CNS transmission do interact in a synergistic way with each other, and often it's difficult for the patient to manage those drugs, so really care must be taken. I'm not going to dwell on the date rape aspect of this, but again, benzodiazepines and another type of drug called gamma-hydroxybutyrate are used as in date rape situations, and when a woman reports that this has happened and there's difficulty with memory associated with it, these drugs should always be tested for, because they do have a relatively long half-life and can still be detected the following day. There are some non-benzodiazepine GABAergic drugs. You've heard of these, I'm sure, on TV, Ambien and Lunesta. These are interesting compounds that do not bind to the benzodiazepine site, but they do work in an allosteric way to enhance GABA receptor function. They don't have much anxiolytic activity, and you'll recall from the earlier lecture I told you that the alpha-2 containing GABA receptors are the ones that drive the anxiolytic effects of benzodiazepines. These drugs are more selective for alpha-1 containing GABA receptors, and the alpha-1 receptor seems to be more important for sedative and anxiety effects. The drug makers will tell you that these drugs produce minimal tolerance and physical dependence. I would not recommend chronic, regular use of these compounds. Again, they're really good for an acute situation. I take Ambien if I'm on an international flight and I'm flying overnight and I have to work the next day because I need to sleep on the plane. But regular use, you can still develop tolerance. Yes?
So, like, what is the main difference between prescribing, like, Ambien versus benzodiazepine?
Well, so the Ambien and Lunesta, I can never pronounce that drug, the zopiclone, they have preference for alpha-1 containing GABA-A receptors, whereas the benzodiazepines, they bind with high affinity to alpha-1, alpha-2, alpha-3, alpha-5 containing receptors. So the zolpidem has very little anxiolytic effects. It really only produces sedation.
Okay.
So if you give Ambien to somebody, they'll feel sleepy, but they won't feel less anxious.
Okay.
Okay? And they bind to a distinct site than the benzodiazepine. They don't actually bind to the same site, so that's why they're called non-benzodiazepine. I won't dwell on barbiturates because we talked about these last time, and these really are not used very much anymore. And they're not used because of their side effects. These drugs directly, at high doses, can directly activate the GABA-A receptor, even without opioids or alcohol being present. So unlike benzodiazepines, which are only positive allosteric modulators, barbiturates can directly activate the GABA-A receptor at high levels, and they can suppress respiration all on their own. So that's why they're largely replaced. And I told you that SSRIs, serotonin reuptake inhibitors, have largely replaced the benzodiazepines for chronic treatment of anxiety disorders. One other drug I'll just mention is another serotonergic drug called buspirone, or Buspar. This is a partial agonist at the 5-HT1A receptor. And more recently, it's also found to be an agonist at the dopamine D3 receptor. And this medication is also used clinically for the treatment of anxiety disorders. Just like the SSRIs, it takes a couple of weeks for the effects to actually engage, but it's relatively safe for chronic use and is quite effective after a couple of weeks. So what typically will happen is that patients who are suffering from an anxiety disorder, if they present at the clinic for the first time, they'll still probably be prescribed a benzodiazepine for the first couple of weeks, and they'll also be prescribed either buspirone or an antidepressant. And over the course of the 2 to 3 weeks where the antidepressant or the buspirone start to produce their effects, you can taper off the benzodiazepine. And then, of course, there are other non-benzodiazepine anxiolytics, and the SSRIs are used very, very commonly today. Tricyclic antidepressants or MAO-I inhibitors, which are old families of antidepressants, are not used very commonly anymore. There's some evidence that Drugs like pregabalin, which is a calcium channel antagonist, may have some promise as an anxiolytic. Certainly drugs that target the noradrenergic system have anxiolytic effects. They're not widely used, but occasionally they are still prescribed. They have significant side effects. And alcohol, the original anxiolytic, which I strongly do not recommend for the treatment of anxiety disorders, but it is acutely anxiolytic. And in terms of how the 5-HT1A receptors work, won't dwell on this, but serotonin is primarily released from the raphe nucleus in the brainstem, and the raphe projects throughout the brain, so serotonin plays a really important role in many parts of the brain. And 5-HT1A receptors kind of act like those metabotropic GABA A or GABA B and glutamate receptors. Their main effect is to regulate serotonin release at serotonergic synapses, and also GABA and glutamate and dopamine release at other types of those synapses. So they act primarily as presynaptic auto or heteroreceptors to regulate neurotransmitters. Okay, and so that's anxiolytics. Any questions about those? Yes.
Are the SSRI used as a monotherapy to treat anxiety or with other medications like risperidone?
As I just said, for chronic treatment, they are the gold standard now. So if somebody is diagnosed with generalized anxiety disorder and they're going to need to be on the medication for months or years, it's very common to use an SSRI alone. But as I said, if they're suffering really bad symptoms when they present at the clinic the first time, the doctor will probably prescribe a benzodiazepine first to provide immediate relief, and then over a couple of weeks, the SSRI will start to relieve the symptoms, and they can taper off the benzodiazepine. It just, and I'm sure they talked to you about this at the depression lecture, why it takes 2 weeks for these antidepressants to start producing antidepressant and anxiolytic effects is still a matter of a lot of debate that we do not have time to get into, but it's fascinating because the animal models that led to the discovery of these drugs, like the antidepressants, the SSRIs, the drugs work right away. So I won't get into this, but the tests that we use to study the antidepressants that were used to screen these compounds, the drug works immediately. And yet, and the test is predictive for the antidepressant effects in the clinic, but those effects in the clinic take 2 weeks to develop. So there's an example where you have good predictive validity, but lousy construct validity, because clearly the test that we're using in the lab is not using the same mechanism that the actual depression is developing, is using to show the symptoms. Okay, we will go through anticonvulsants fairly quickly here. I'm going to talk to you very briefly about the genesis of seizures, and we're going to talk about how we treat seizures. And I'm really going to emphasize 2 broad classes of seizure disorders, and they have different neuropathology, and they're treated with different classes of drugs. And that's really the take-home I want you to take from this part of the lecture, is that epilepsy is one of the best examples where we learned that even though there's one disease called epilepsy, there are subtypes of seizure disorders. And it wasn't until we recognized that the underlying neuropathology in some of these disorders was completely different that we were able to develop effective treatments for these disorders. And that's a lesson that I think we'll appreciate and learn in other areas like the treatment of anxiety disorders and addiction, because there isn't just one anxiety disorder, there probably isn't just one addiction or path to these disorders. And part of the reason that we have such a hard time treating them is that we keep thinking one drug is going to be effective for everybody. And even if the neurobiology is distinct, this is really clearly illustrated with epilepsy. So that's what I'm going to emphasize here today. Most of the drugs, or many of the drugs, are drugs that we've already touched upon, so I won't go into them in much detail. Epilepsy affects quite a few people, 50 million people worldwide, about 2.5 million people in the United States alone, and about 150,000 new cases diagnosed each year. Also, often affects children. And 70% of patients with epilepsy have to treat their seizures with drugs. And unfortunately, many of them suffer side effects that are significant enough that it's really negatively impacting their quality of life. And there's still an urgent need for better pharmacotherapies, even though this is an area where we've seen a lot of new drugs over the last 20 years. So again, I don't have to go through all this because we talked about the basis of synaptic transmission in the earlier lecture and how neurons communicate with each other at the synapse, excitatory or inhibitory synapses. And to simplify everything and save a little bit of time, epilepsy is essentially, and not surprisingly, a disease of synaptic communication gone awry. And if you think about what a seizure is, too much excitability, you either have too much glutamatergic transmission or not enough GABAergic transmission to buffer. And that's really the underlying problem. And again, you have voltage-gated channels that mediate synaptic transmission. Some of them are found presynaptically, like calcium channels that regulate transmitter release. And the ligand-gated channels, like the GABA-A and the AMPA receptors that mediate fast synaptic inhibition and excitation. I'm just going to mention a couple of properties of these channels because that's going to be important for how some of the drugs work. The only biophysical property of voltage-gated channels I want you to keep in your heads is that when a voltage-gated channel, this is a channel that's gated by a change in the transmembrane potential, like a sodium channel or calcium channel or potassium channel. When the membrane potential depolarizes, most of these channels go through a conformational change, right? So the channel's not conducting at the resting membrane potential. Sodium channels are closed at the resting membrane potential. When the membrane potential depolarizes, maybe a glutamatergic response kicks in. You get this opening of the channel and a rapid influx of sodium that drives the rising phase of the action potential. But many of these channels will. Oh, no problem. Many of these channels will close even though the signal to stay open is still there. They will inactivate. This is analogous to the desensitization of the GABA receptors we were talking about in my first lecture. Just to confuse you, for voltage-gated channels, they refer to it as inactivation. But essentially, it's the same as desensitization. The stimulus to stay open is still there, but they inactivate. And for some of these channels, like the sodium channels that mediate the action potential, the inactivation is incredibly fast. So they open and close within less than a millisecond. Very, very fast. And then they can't open again until this inactivation has been relieved by turning back to the resting membrane potential. So that's just what you should keep in mind for voltage-gated channels. They're gated by a change in transmembrane potential, and many of these channels show this rapid inactivation. The other thing to keep in mind is that different neurons throughout the brain, different parts of the brain, express different complements of voltage-gated channels. And so, depending on what complement of channels they express, that sort of drives the pattern of activity that you can see. And we'll talk about this a little bit more as we go through this lecture. But there are certain parts of the brain where the cells just tend to be more likely to be excitable or burst or show the kind of electrical activity that could drive a seizure. Cells in the thalamus that are particularly vulnerable to this. And it's because of the complement of channels, the voltage-gated channels that they express. And of course, we've already talked about the ligand-gated channels, so I'm going to skip this. These can be excitatory or inhibitory. GABA is the inhibitory one. It drives inhibitory postsynaptic transmission. Glutamate is the excitatory one. It drives excitatory transmission, primarily through AMPA receptors, but also through and NMDA receptors. And I showed you this last time, but I'm going to show you this again because this is really important for epilepsy. If an excitatory postsynaptic potential depolarizes the membrane, you'll see this. If it's large enough to actually generate an action potential, you'll see the action potential. And the inhibitory postsynaptic potentials that are mediated mostly by GABA-A receptors, they hyperpolarize the membrane away from the action potential threshold. And what I mentioned last time, and I'm going to emphasize again, is that what's really happening if you're recording from any neuron in the brain is that they're not just receiving an excitatory response or just receiving an inhibitory response. There's a balance between the two. And it's that balance that allows for normal synaptic communication to occur. And this is exactly what it looks like. And what we're going to talk about is sort of the genesis or the origin of the seizure. It's nothing more than this balance sort of gone awry, that the excitation becomes too big, the inhibition becomes too small, and it leads to aberrant and excessive excitability in a discrete population of cells. And that, it's called a paroxysmal depolarizing shift. And what you'll see is it looks just like this, only this part is exaggerated and this part gets inhibited, is shrunken. So just keep that in mind, that the origin of the seizure is really nothing more than the normal balance of synaptic communication being disrupted. I don't have the, I forgot to put the link here, but it doesn't matter, you can still see it. I'm trying to illustrate. This is a thalamic relay cell that's actually really important in the type of seizure we're going to talk about in a little while. And these cells actually have what's called a bistable membrane potentials. They're perfectly happy being at minus 80 millivolts or being at around minus 50 millivolts. And they're intrinsically, these cells don't need synaptic transmission to fire. They have a complement of voltage gated channels that allows them to just fire away rhythmically, even if you take them out of the brain and put them in a dish. And at the hyperpolarized potential, this is the pattern of activity that they show. Very rhythmic, pacemaker-like activity. But if you depolarize these cells, imagine an excitatory postsynaptic potential drives them to this lower membrane potential, channel activity changes, and I'll talk about the channel that's really involved in this. And now instead of getting this uniform activity, you see this bursting-like activity, totally different pattern. And when you hyperpolarize back to the minus 80 membrane potential, the activity becomes pacemaker-like again, just because of different types of voltage-gated channels that are inactivated at this potential. So neurons are excitable cells. They use electrical signals to communicate. And the distribution of voltage and ligand-gated ion channels really varies dramatically between different populations of neurons. And the complement of channels that are expressed really influences the pattern of neural activity that you're going to see. All right, let's talk about epilepsy. When we talk about epilepsy, we think about a seizure. That's the event that leads to the initial diagnosis of the disorder. So a seizure is the clinical manifestation of an abnormal and excessive excitation of a population of neurons. Has anybody here actually witnessed a seizure? Yeah, so you know what they can look like. And there's different types of seizure disorders, but some of them can be very, very dramatic. I didn't have time today to show you videos of this, but you can Google the types of seizures I'm going to talk to you about, and you can see them. They can be really quite dramatic, and obviously debilitating to somebody who's suffering from these. But a single seizure is not epilepsy. There are rare instances where a seizure can be brought on by something like a really high fever or a traumatic insult to the brain. That's not a seizure, or that's not epilepsy. Epilepsy is a tendency towards recurrent seizures that are not a result of a systemic or neurological insult. And in some people who suffer from these disorders, they can have these daily, even more than once a day, and without treatment, it can be very debilitating. Epileptogenesis is the sequence of events that converts a normal neuronal network into a hyperexcitable network. And this is what I really want to emphasize to you today, that over the years we've come to appreciate that there are two broad classes of seizure disorders. And I give this lecture to medical students, and it can get a little bit confusing. I don't want you to get confused because the main point is just to understand the two broad classes. There are seizures that have a defined focus in the brain. So they originate in a specific area of the brain. Something has happened to that area, and the balance of excitation and inhibition in that specific area has gone awry. There's too much excitation or not enough inhibition. Those are called partial seizures. And those are contrasted with another class of seizures that are called primary generalized seizures. These are seizures where if I had EEGs hooked up to your brain at the time of the seizure onset, I wouldn't see a focus. What I would see is almost instantaneous excessive excitation throughout the brain. And these seizures look completely different from each other. It's interesting, on the EEG, the primary generalized seizures look much, much worse because everything is happening at the same time. But behaviorally, the partial seizures, or certain classes of the partial seizures, can actually look much, much more dramatic. And that is where it gets a bit confusing. So bear with me. A partial seizure, there are different subtypes. Let's say your seizure focus is in the amygdala or the hippocampus, okay? If only that part of the brain becomes epileptogenic, then that's called a simple partial seizure, okay? Because it's simple, only one part of the brain. And what you might experience with that is just like an emotional state or a weird feeling or something like that. There may not be any physical manifestations. But in many, many cases, a partial seizure that started in the hippocampus or amygdala will spread and will recruit adjacent parts of the brain that it's interconnected with. That is called a partial complex or a complex partial seizure. And these may have more dramatic behavioral representations. And even more commonly than that, the contralateral hemisphere, because you know that both sides of the brain are very interconnected with each other, a simple partial seizure that started in my left hippocampus could eventually recruit the entire brain. But it takes time. It happens over seconds. It's not instantaneous, seconds to minutes. And so a partial seizure can also become generalized, but we refer to it as secondarily generalized. And the difference is that here, everything happened almost instantaneously, whereas here, there was a defined seizure focus. If I had a magic switch and I could have flicked off the hippocampus, I would have shut this seizure off. But here, it seems like things are happening much, much more quickly. And the one example I want you to remember is an absence seizure. Has anybody seen an absence seizure? We'll talk about these briefly. These often affect children, and even though the EEG looks really horrific, what's actually underlying, what the child actually expresses is really relatively minimal, and it can be very hard to diagnose, but it can be obviously detrimental. Don't worry about the myoclonic one. So I'm going to just briefly walk you through a partial seizure that becomes secondarily generalized. Yeah.
How's like a generalized seizure, like how does it get the whole brain instantly? Like, you know what I'm saying? Like, shouldn't it always start focally and spread out, or is it just a coincidence that?
No, this is where it gets complicated, and I don't have a lot of time to get into it. The primary generalized seizures do kind of have a focus, but the transition from that focus to the whole brain being dysregulated is almost instantaneous, and I'll explain to you why that is.
Okay.
So they have distinct mechanisms that drive them.
Okay.
So the partial seizures that become secondarily generalized, it really does take seconds to minutes for this to develop. And you'll see that in these patients, they have something called an aura, where they may feel like the seizure is starting to come on, and that's because, let's say, the hippocampus is starting to go awry. But it takes a certain amount of time for it to start recruiting the neighboring areas. It doesn't happen instantaneously. But with the absence seizure, there is obviously an initial source that's triggering it, but it happens much, much quicker. So basically, there are many factors that can cause a seizure. The symptoms of a simple partial seizure really depend on the location. So if your focus is in, let's say, motor cortex, you may actually experience finger twitching or some kind of muscle twitch. But if it's in the hippocampus or amygdala, you may experience an emotional state or an unusual feeling. And these partial seizures that become secondarily generalized usually follow this progression. There's an aura, where you have this initial feeling, and this is because the partial area is getting engaged first. There's a synchronization that occurs within the seizure focus, and this is where neurons within the hippocampus or the amygdala start to sort of synchronize, and their electrical activity goes awry together. And then, if that isn't handled and it doesn't stay contained, that seizure will begin to spread to neighboring brain regions that are interconnected with that focus, and then to the contralateral hemisphere. And once both hemispheres are engaged, and again, this takes seconds to minutes, the seizures become secondarily generalized. And this is where you'll have a full-blown seizure. I'll walk you through the steps of it. And then after the seizure abates, you have what's called a postnatal period, where everything quiets down for a while. So this is the normal firing pattern of a neuron, let's say in the hippocampus or the cortex, and everything is just fine. But if I do something to shift the excitatory inhibitory balance, like blocking those GABA A receptors, and I give the same kind of stimulus to drive an action potential, instead of getting one action potential, I get this big burst. And even if I hyperpolarize the membrane away from the resting membrane potential so that I don't reach action potential threshold, you still see that there's a very large depolarization. This is because you've removed GABA. You've completely shifted the balance I showed you between excitation and inhibition. Well, obviously, in a seizure, it's not that GABA is completely gone or you'd be dead, but GABA is probably compromised in major ways, and so there's excessive excitation and a lack of inhibition. And this is exactly what it looks like. It's called a paroxysmal depolarizing shift. And what happens is that during the initial phase, let's put this up quickly here. During the initial phase, you have AMPA receptors driving the depolarization just like you would during a normal EPSP. But because the GABA system is somewhat compromised, instead of getting maybe one action potential, you get a train of action potentials, a prolonged depolarization, too much NMDA receptor activation, voltage-gated calcium channels now being activated, so essentially a really big depolarization in that neuron. But inhibition is still there, and it takes longer to sort of quiet things down, and eventually it usually can. And if it does, then the seizure is not going to spread. But what will happen is that eventually this starts to fail, and the seizure will begin to spread. So it's this after hyperpolarization that's kind of the limiting factor. If it fails, the seizure will spread and become secondarily generalized. And that's why most of the treatments target the GABA, initial treatments target the GABA system to try to prevent that seizure spread. And this is what an EEG of a patient with a partial seizure, so just happening in the area where the seizure is originating, this is what the EEG would look like. And it's actually hard to tell what's going on. You need to be a real expert at reading these to actually see that this activity on these two leads, which were over the temporal lobe, were showing aberrant activity. It's not obvious. Once the seizure spreads, the EEG becomes really clearly dysregulated all over the leads. But initially, in the seizure focus, it's just those areas that are showing the aberrant activity. And I already talked to you about the surround inhibition, the way the GABA system works to control excitability. This is really key, that the feed forward and feedback inhibition of the GABA system is wired to prevent excessive excitation. But during the development of a focal seizure that spreads, this surround inhibition is overcome, the after hyperpolarization disappears, and the seizure spreads beyond its initial focus. What causes the surround inhibition to fail? We know lots of things that we can do in the lab to cause it to fail, but the honest truth is in most cases in patients suffering from seizure disorders, or from the seizure disorders, we just don't know. If the seizure focus is intense enough, the activity spreads to neighboring populations, and then you'll start to see the behavioral symptoms. And if you've ever seen what's called a tonic-clonic seizure, essentially what happens is the patient's muscles go really rigid for a short period of time, and they may collapse, and then they start to have like a jerking motion of their muscles for a period of time. And then in most cases, the seizure will abate all by itself. If it persists for more than, I forget, 5 or 10 minutes, then you want to call 911. But in most cases, they recommend that you just make sure the person is safe, that they're not going to hurt themselves. And once the seizure abates, they're no worse for wear, and they can just resume their normal function. Of course, the problem is if they were driving or doing something, it would be horrific. And so these seizures really do impact quality of life. So during the initial 30 seconds or so of a secondarily generalized seizure, neurons in the involved area undergo a prolonged depolarization. So this is what's causing that rigid muscle contractions. Essentially, GABA has completely failed. There's no inhibition, and the neurons stay depolarized for a very long time. Neurons don't like to stay depolarized for tens of seconds. Usually it's just brief millisecond periods of time. So this is really abnormal and produces that tonic phase of muscle contraction. And then during the clonic phase, where you start to get the jerking motion, muscle movement, the GABA system begins to come back online, and you start to get those paroxysmal depolarizing shifts returning for a while. And that's what causes the clonic phase. And then eventually the GABA system strengthens enough to quiet everything down. And that's just shown here. Following the tonic-clonic phase, there's a period of decreased electrical activity, and this is the post-ictal period. And this is where the patient may be confused, drowsy, or even exhibit some neurological deficits. But again, for the most part, they're usually no worse for wear after the seizure. And only if it doesn't stop after 5 to 10 minutes would you even have to call a doctor to get medical attention. So that's a partial seizure that becomes secondarily generalized. Yes?
What's the mechanism that the seizure will stop by itself within a few minutes?
Why it wouldn't stop by itself?
Why it stopped?
Why it stops? Well, two things I think are happening. We don't know for sure, but two things I think are happening. One is the GABA system is there, it's just weaker, and eventually it can start to take hold. The other is that eventually the excitatory drive wears itself out. So the physiological processes that are driving that excessive activity, they take energy, and eventually the energy gets depleted, and so the glutamatergic transmission starts to get calmed down by itself. So that's why it kind of just has a self-limiting cycle. It can't go on forever. The brain cannot sustain that amount of electrical activity indefinitely. Although, I say that, although there are cases, like I said, where it will not stop, status epilepticus, and in rare cases, the brain can continue to show that activity. So we don't know for sure why it stops by itself. My best guess is that the GABA system is still there, and it's eventually able to sort of quiet things down. It's just weaker. I mean, keep in mind, these patients don't have, most of these patients don't have seizures continuously, so they can engage in normal synaptic communication when they're not suffering a seizure. It's just that when aberrant activity begins in the focus, the brain's not able to contain it, and that's why. So there must be a weakness in the inhibitory circuitry that's allowing that to happen. It's a good question. Okay, we are running out of time, so let's move on to the primary generalized seizures. This is what the EEG of an absence seizure looks like. And it looks absolutely horrific, right? All the leads are showing this activity, and although there is a focus, it's the transition is very, very brief. And I will tell you that although this looks horrific, the patient's only expression might be blinking or withdrawing and almost looking like they're staring off into space. And it will last for about 30 seconds, and then they'll come back. And that's why these seizures can be hard to sort of diagnose. And you're saying to me, how can the brain look like this and there not be huge motoric effects? And that's because this pattern of activity is really an exaggeration of the normal spike and wave discharge that happens during sleep. What's actually happening in an absence seizure is that you're getting a sleep-like pattern of activity in the awake state. And that's actually what's going on. Like, it almost is as if they're dissociating from consciousness for a brief period of time and then coming back. So it looks horrific, but trust me, that there are it doesn't cause muscle contractions or the patient doesn't collapse. And in fact, kids can have this for months at a time, and it can be very hard to diagnose, and a teacher really has to sort of pay attention, or a parent has to pay attention and notice that the child is actually experiencing this. So it begins with a sudden, very suddenly, 10 to 30 seconds, you get a loss of awareness, you might get blinking or lip smacking or something. That's the extent of the motor changes, but you do see that very large spike and wave EEG pattern. And these seizures are not preceded by an aura, and they don't really have a post-ictal period. The videos I've seen of an absence seizure, the child looks completely normal immediately after it stops. And just in the interest of time, I'm not going to go into the mechanism of this seizure, but what's going on is that those thalamic relay cells that I showed you that can have two membrane potentials and they can burst, they express a type of calcium channel called a T-type calcium channel that drives that bursting activity. And we know that these T channels are very important in the spike and wave discharges that we see during sleep. And somehow these T channels are too active in these patients, in the thalamic relay cells, and they drive sort of excessive bursting activity to occur at a time when they shouldn't be, because the patient's awake. And if that activity occurs, it immediately produces that EEG pattern across the brain that you saw. But it's really just an exaggeration of normal sleep patterns, so that's why it's not associated with massive motor dysfunction. It's really just a sleep pattern that's emerging during consciousness. Let's see if we have to get to some of the drugs quickly here. So, in terms of the treatment of these disorders, what I really want you to take away just in the last 10 minutes is that the drugs that we use to treat a simple seizure with a defined focus that may or may not become secondarily generalized are usually different from the drugs that we use to treat this absence seizure. There are some drugs that are effective for both. Those have been discovered more recently, but it wasn't until we discovered these sort of, actually the drugs came first. It wasn't until we discovered that there were different drugs that really targeted these two classes of seizures that we were able to treat the absence seizures. And in fact, drugs that are used to treat the secondarily generalized seizures, especially the GABA drugs, they can actually exacerbate absence seizures. So it's really critical to understand that those partial seizures that may or may not become secondarily generalized, they involve the compromised GABA system. Those absence seizures do not. It's really these T-type calcium channels that are driving the aberrant activity there. So really, up until about 100 years ago, we had no treatments for seizures. People used to think that people with epilepsy were possessed by demons, they were locked up in institutions, they were treated horribly. And it wasn't until barbiturates were introduced that we had any way to medicate these patients. And as soon as we did, we realized, oh my gosh, there's actually a physiological basis for this, and we can address the seizures. But as I've talked about a couple of times, barbiturates are not an ideal treatment because at high doses they can be toxic. But the fact that the barbiturates target the GABA system, once we realized that, many medications have been developed that target the GABA system. And you can sort of look through these. I don't want you to memorize the drugs, I just want you to understand that the GABA synapse is a very important target for anti-epileptic drugs. We've already talked about the benzodiazepines. They were used, they replaced the barbiturates in the 50s and early 60s and were the main treatment for many types of seizure disorders for quite a few years. But they have a number of side effects. Another drug that was very popular, still is today, was a drug called phenytoin or Dilantin, and a more recently approved drug with the same mechanism, carbamazepine, was approved in 1974. These were much better tolerated. They didn't have sedative or hypnotic effects like the benzodiazepines did, and they seemed to reduce the frequency of seizures in patients with those partial seizures that become secondarily generalized. Not effective for patients with primary generalized seizures. And they have a neat mechanism of action. And it comes back to that inactivation of sodium channels. Remember I told you the sodium channels tend to inactivate fairly quickly, but with really sustained depolarizations, there are enough of them that you can get really aberrant bursting activity. But what these drugs like phenytoin and carbamazepine do is they stabilize that inactivated state. They actually only block the channel once it's open, kind of like magnesium ions block the NMDA receptor. This channel has to open for the phenytoin to get in, and as soon as it does, it kind of stays there, and it prevents excessive activity. So you can get one normal action potential, maybe a couple of action potentials, but you can't get bursting-like activity. And so it probably reduces the spread of the seizure without having as big an effect on normal synaptic transmission. And then the big breakthrough came in 1960 when this drug, ethosuximide, was discovered. This drug, we didn't know it at the time, but it selectively blocks those T-type calcium channels that are driving the bursting activity in the thalamic relay cells that cause that aberrant EEG in absence seizures. And this drug was amazingly effective in the treatment of absence seizures. It was really the first medication that was really effective for absence seizures, these kids who suffer from that primary generalized seizure. And it's not effective for patients with partial seizures that may or may not become secondarily generalized. And this was the breakthrough that really drove home the idea that there were different mechanisms driving these seizure disorders. They didn't know what T channels were at the time, but this led to a lot of research that led to the discovery of the differences that are underlying these two seizure disorders. And really, just in the last few minutes here, you do not have to memorize these drugs, but I'm just going to walk through some of these and point out some of the ones that are more important. Since the discovery of valproate, some drugs have been discovered that do seem to work on both types of seizures. And that's because these are dirty drugs that interact with probably the GABA system, the glutamate system, and these T-type calcium channels, or other things that control excitability in thalamic relay cells. We often think that the perfect drug would be a drug that targets only one receptor. Most of the medications that are out there that treat neurological disorders probably have subtle effects on many different systems, and that's why they're well tolerated, and maybe that's why they produce the relief of the symptoms associated with neurological disorders. When you target a specific receptor system and only that receptor system, you often have very dramatic effects, and the drug probably isn't going to be safely translated to the clinic. So valproate is the first example of that. You can Google valproate or PubMed valproate and any neurotransmitter that you want, and I bet you'll find a paper saying that it interacts with it. So its mechanism of action is not traced to a single receptor or ion channel. Most of these drugs have very long half-lives, and they were developed that way so that you might have to take them once a day. They do induce liver cytochrome P450, so they can interact with other drugs as well, so you have to be aware of what other medications the person with epilepsy is taking. And then starting in the 90s, a whole host of drugs were developed. And again, I'm not going to go into detail on this because it's beyond what you need to know for this class. This drug came out when I was a graduate student. I remember how excited everybody was about it because this drug in animal models was phenomenal. And interestingly, in clinical trials, it looked like a magic bullet. It was really effective in all kinds of seizure disorders. Very complex mechanism of action. But as soon as it was introduced into the clinic, there were rare but fatal side effects that something called aplastic anemia that occurred in some patients, and it had to be removed from the clinic. It was really unfortunate because it was really efficacious, and still today, in cases where a patient doesn't respond to any drug, this drug will still be used, but obviously the patient will be very carefully monitored for this very serious side effect. But it's no longer used today. You've probably heard of Neurontin or Lyrica from TV commercials. These are interesting drugs that are used often as an add-on treatment, so to reduce the amount of the main anti-epileptic drug that's needed. And they're quite effective in doing that. So sometimes you can get better therapeutic treatment by combining two medications, lowering the dose of each, achieving symptomatic relief, and improving the side effect consequences. I point these out because they were initially developed as GABA drugs. The pharmaceutical companies were trying to make a better GABA. And it turns out that these drugs have nothing to do with the GABA system. They do not influence GABA transmission. 10 years of work proved that more or less unequivocally, that they don't directly influence the GABA system. They bind to some subunit on calcium channels called the alpha-2 delta subunit. And it's their binding affinity to this site that correlates with their ability to relieve seizures in animal models and in patients. And we're still trying to understand what this subunit does and how it influences excitability, but at least now we think we know the target. You can browse through these. There's a lot of drugs that target the GABA system. This drug, levetiracetam, Keppra, is being used with increasing frequency in the clinic. Again, its mechanism of action is not well understood, but this drug is probably one of the most successful medications to be introduced in the last 10 or 15 years. And it also has a very bizarre mechanism of action. Up until a couple of years ago, I never even talked about this, but recently it's been discovered that there's a protein on synaptic vesicles called SB2A. Synaptic vesicle protein 2A. And it seems to be the binding site for Keppra. So that's great. We now know where it binds. We still don't really know what SB2A does, and so there's a lot of work trying to understand that because this drug is so successful in the clinic. Just point out a couple of very recent drugs. Medigabine is a first-in-class potassium channel blocker that has been approved as an add-on treatment in adult patients with simple partial, what are called focal seizures, and it's showing some promise. And this is maybe one of the most exciting ones, perampanel. This is the first drug that targets the AMPA receptors. It's called the selective non-competitive AMPA receptor antagonist, and it's being used also as an add-on treatment in adult patients with focal seizures with and without secondary generalization, and it's showing some promise in the clinic. And the reason these are important is that if a drug is targeting a novel site and it's the first FDA-approved drug there and it works, you'll see a host of new medications coming to market to treat this. And this is just a handy list that you can look at. And really what I want you to remember is that ethosuximide, that T-channel blocker, is really the drug that was used to target the absence seizures. It's not efficacious for the treatment of partial seizures that become secondarily generalized. And a lot of the drugs that are used to treat partial seizures that become secondarily generalized, like phenytoin, really don't work for the absence seizure. Yes, you do have drugs like valproate that are effective against all of them, but the drugs that are more selective really target one or the other. The reason that a drug like valproate may work on all of these is because it has subtle effects on many neurotransmitters. That's the summary of what I just said. And I'm just going to, in 1 minute here, tell you that there are some ways to treat seizure disorders that don't involve drugs. If there is a very defined seizure focus, like the hippocampus or the amygdala, and in rare situations, that focus is accessible to a surgeon's knife or to something like gamma radiation, and you can ablate that part of the brain safely, you can cure the patient of the seizure disorder. Unfortunately, this doesn't come up very often. Often the seizure focus is very hard to get to, it's poorly defined, or it's not accessible to the surgeon's knife. A really interesting development over the last few years is that it's been discovered that if you stimulate the vagus nerve, you've all learned about the main nerves that control, that go from the periphery to the brain. The vagus nerve actually is a two-way highway. It takes information to and from the brain, and it's been shown that the specific types of stimulation of the vagus nerve can suppress seizure activity. And there's now an FDA-approved device that's like a pacemaker for the vagus nerve that's being used successfully to treat patients with seizure disorders. This is showing real promise because the patients that were used in the clinical trial were actually patients who were completely non-responsive to traditional pharmacotherapies. And about 40 to 50% of them showed significant improvement with this device. So that's looking really encouraging, and I think we're going to see more treatments like this in the near future. And the last thing is the ketogenic diet. It's been known for over 100 years that a diet that has a very specific balance of high fat to low carbohydrate protein is very effective at reducing seizures. Now you're thinking, why would you want to do this? This is going to give you a heart attack. Well, again, some kids especially are so resistant to treatment that parents would try anything. And they discovered that for reasons that weren't appreciated at the time and are still not fully understood, that this kind of diet, and it's a very specific ratio of fat to carbohydrates, like 4 or 5 to 1, promotes ketone generation, and that somehow suppresses excitability and blocks the seizures in these children. And there are clinical trials going on right now, and I think Wake Forest is part of one of them, to try to understand, first of all, does this really work under controlled conditions? And more importantly, why does it work? Because if we can understand what's actually causing the beneficial therapeutic effects, there might be less greasy ways to administer the diet and still get the relief of the seizures. So I apologize for rushing through this part, but I've emphasized the things you will need to know for your test. And if there are any questions, just let me know.